Hello and welcome. Hi, everyone from all around the world to the EAO Just Live session tonight. It's the last EAO Just Live session in this year. In Germany, at least, snow is already coming down, but we have a lot of visitors already from all around the world, but probably the weather is way better. So we have Kali Shupla from Uganda logging in. We have Alberto from Mexico logging in, probably way better the weather. We've also Nicole from Sweden here, so I'm not sure about the weather there. And we have, of course, the most important one tonight. We have Professor Wael Att here from Boston in the United States. Wael, it's my pleasure to have you here. And how is the weather in Boston? I remember Boston to be very, very chilly.
Well, it's a pleasure to see you and chat with you again, dear Stefan. I can say absolutely the weather here is way better than in Germany at the moment. So we have the sun out, we have like a sunny day, no clouds. It's a beautiful one, chilly, yet it's a nice weather here.
That's good to hear that. So let me quickly introduce you. You are actually, we share some common things. We spend some time at German universities. We spent some time in academia. You were part of the famous Prosto department in Freiburg, Germany, did all your academics here in Germany. You are world-renowned speakers. You then went to US. You were in US beforehand also. You were the former chair of the Tufts University in Boston, and now you settled for your own private office. Congratulations again to that. I don't think I need to introduce you to anyone. You're an expert in the field of digital implantology, also immediate loading, immediate implant placement. And actually, Wael, this is why we have you tonight here. So welcome again.
Thank you so much, Stefan. Appreciate the introduction.
Thank you. So, dear friends, please log in and tell us in the chat where you're from. This always helps us to feel a little more warm. If you tell us you're from the Maldives or from Mauritius, that helps Wael and me a little bit in this chilly spot. So please type in your questions. We will just have a discussion about this topic. The topic is how to manage immediacy in full arch cases today predictably. And while actually a case came across me, and I thought I have Wael Att tonight talking to me. He's the typical expert, and let me just quickly show you my case, which came across my mind these days. And it's a case, a patient. He's a perio patient, and as you see, rather low smile line, elderly patient. He's in his perio maintenance, but I would say he will lose all his upper dentition because of caries, because of perio, because of endodontic failures, and so on. And this is where I stand now. And now I need your help, Wael. I ask you to just combine a few slides for us to give us an idea of how your concept is in these full arch cases, in these failing dentition cases. So please, everyone, ask your question also while Wael is presenting. We would be more than happy to have a very interactive format. And Wael, please help me with this patient. How should I proceed, my friend?
Well, I appreciate it. Thank you so much, Stefan, and thank the EAO for giving me this opportunity of being here tonight, and welcome everyone who joined us for this kind of interactive live session. Where I think we can benefit from all of each other and hopefully be able to learn something to better serve our patients. And back to your patient, Stefan, this is exactly what I will be dealing with tonight. But before I jump into the topic, we have to recognize that planning is the most important aspect of every case in terms of delivering a predictable outcome. So we always say 90% of the case is planning, and then 10% I say is execution. I think a lot of other colleagues, they share with me the same thing. So by looking at your case, and if we are going to consider the different treatment options after setting, of course, collecting all of the information, you took the photos, you took the x-rays, you did the comprehensive charting, whether it's dental, periodontal, you set the prognosis of the teeth, and then from there you go to the treatment. planning. And you have, of course, different avenues here. Back to your case, if we are going to take all of the upper teeth in the jaw, you have the option number one, which is I would say the most economic, the fastest one for the patient would be a complete denture, no implants or whatever. No,
which we actually, sorry to interrupt you, we had just live, we had Nelson Silva here, who exactly showed us this, how to go via a full complete denture. What's quite interesting, and I think this is a viable option.
Yes, and it's the first option that we offer to our patients, because you have also to consider the economic status of the patient, and also from an anatomic standpoint, whether if they need an implant, if you need to introduce additional stuff, like, for example, enhance the bone around the implants or where the implants are going to be placed, or you will have to work on the soft tissue or additional measures. And now we talk about the second option, which is you are going to add implants or install implants or place implants that are going to be limited in number. Let's talk in the upper jaw, the minimal number that we think about for implants to support either an implant retained fixed removable partial denture, or we can think about like an implant supported removable option. And that would differentiate in terms of what kind of support. Is it going to be solitary attachments or splinted attachments? No, it's not the topic of today. And you have then the third option, which is by far is the most expensive one, and it's the one that requires the more precise planning, which is the implant-supported fixed rehabilitation. And for this, of course, you can start by a minimum number of 4 implants. But of course, if you are thinking about loading these implants at the same time of tooth extraction and implant placement, in other words, immediacy, I would rather to go for 6 or sometimes 8 implants as a number. And I will explain why. But regardless, I mean, we have all of these treatment options, and we have to discuss them with the patient to have the patient make a decision about what kind of option we'd like to go for. So not to jump immediately into the option that we have in our mind, but we have to present everything to the patient, at least 2 or 3, better 3 treatment options, and then the patient will ask about the advantages, disadvantages, then make a decision in this regards. Now, if I jump to immediacy, which we are going to speak about today, it's a lot, especially I can speak from the US, and it started way before in Europe in terms of immediate implant placement and loading for full arch cases. Now it's a big topic here in the US. We are dealing with a number of issues. Now, if you see here a surgery that we have done a few years ago, patient is going to become edentulous. We are going to place implants. You see how we start these surgeries by extracting all of the teeth, and then we lose all of our references. Then we move on to the next step, which is we are going to deliver these tissue-supported surgical guides with additional anchorage using anchor pins. And then we start the sequential implant drilling. Whether we're doing flapless or with a flap, it doesn't matter, but we place the implants. And when we are achieving that primary stability that we are looking for, and there's of course a debate about when you have multiple implants splinted together, what would be the primary stability or the minimal one. We start now with the fun part. And the fun part is how to deliver your prosthetic components in a predictable way. In other words, how they are going to match what you have planned on the digital articulator or the real articulator. How you're going to transfer it by one-to-one to the mouth. Now we rely on the upper using the palate, and the lower usually is driven by the occlusion towards the upper. So you see here, we started back at that time utilizing metal reinforced temporaries simply because they will not break. And all of us recognize that temporaries, they break if they don't have a metal support on implants, because the patients, they don't have that control in terms of biting and the material properties, they might lead to fracture. But fortunately today we are able with the machinable materials to achieve better mechanical properties. Regardless, these are issues that we recognized in terms of placing the implants and loading them immediately at the same time. And I can summarize these by 3 things. Placement of the implants is not an issue. I mean, we extract the teeth, place the implants. But you have to remember that once you have extracted everything, all of the teeth, then you are losing all references. You are relying on the soft tissue, or if you have a bone-supported surgical guide, you're relying on the bone. So it is not really as accurate as you think, because once you place the implants, it's okay. Then how you are going to use references to place your temporaries where they're supposed to be? And we all know it takes about an hour, for example, to extract, place, and implants, but it takes 3 hours to deliver the temporary. And this is something that all of us recognize. So meaning that the prosthetic part is more challenging than the surgical part. And last but not least, remember that when we are anesthetizing our patients, the patients are numbed, so you don't get a reliable feedback from the patients. And this is very significant whenever you're doing the so-called stackable surgical guides, as you see here on the screen. Now, if you see on the left-hand side, that initial guide, when we are going to put it and ask the patient to bite down on it and drill for our anchor pins, this is the most significant guide, actually, because it's going to dictate all further processes. Now, you drill ask the patient to bite down, you drill for the anchor pins, you remove that initial guide, you put the reduction guide or the bone reduction guide, you cut the bone, and then you place the implants with that stackable implant surgical guide that is stacked on top of the bone reduction guide. Once you are done, you move on to the last part, which is to pick up the pre-manufactured temporary that is resting on top of the bone reduction guide. Now, if you have an issue, let's say that initial guide is rotated, tilted, or not properly seated, you ask the patient, because you're asking the patient to bite down, but they might bite down on the right side more than the left side, or it's not balanced and you don't see it, then everything else will be in an error status. Basically, your bone reduction guide is not in the right position. Your implant surgical guide is not in the right position, and your temporary is also not in the right position.
Wow, just a quick question. Bone reduction.
Go ahead.
How do you decide about the size of the bone reduction? Is that also smile line, or does it depend on bone size to place your implant in the proper bone? Or what are your measures if you design your removal guide for the bone?
That's actually exactly what I'm jumping to now, Stefan. So basically, when we speak about bone reduction, let's just look at the temporary, how it looks like here. It's flat in terms of the base. We reduce the bone, and they tell you that it is facilitating proper hygiene. And we all know, without any filters, that the patients will not be able to clean properly, and that flat base is not going to provide the proper hygiene capacity as we would like to have. So another case, let's see here. If you look at the beautiful soft tissue architecture around these teeth to be extracted, this is not my case. This is one of my colleagues' case that was so kind enough to share with me, because there is something interesting in it. To show you, actually, the case was done in Switzerland. And you see here, the case was referred to the surgeon for extraction and implant placement. So what a lot of colleagues, they do in terms of surgery, they just take on the panoramic radiograph and they draw a line and they say, this is how we would like to have the bone. And then they go ahead and then use the saw or the piezoelectric to cut the bone with the soft tissue and the teeth at the same time. And they justify this. They say, well, you are going to extract the teeth anyway. You are going to extract the teeth. You are going to have an excess of the soft tissue. So why don't you cut this from the beginning and then get rid of it, and it will be easy for you. Now, if you look at it here, you have a wide base to place the implants, and you place the implants and you look at the situation. We can discuss whether it's a huge number of implants or not enough. It doesn't matter. It's not the topic for today, but they have leveled the bone. Now look at the final. Is this really the gold standard that we would like to work on in terms of implant placement and restoration? We started from a situation that is so beautiful in terms of the soft tissue architecture and jumped on to a flat base of the mouth, floor of the mouth. And then we can immediately recognize on the lower anterior implants from the lingual aspect that there is already a kind of peri-implant mucositis there. There is some redness, the tissue seems to be irritated. We know that is not necessarily going to lead to peri-implantitis, but it is more prone to plaque accumulation, more prone to inflammation, which is also disturbing for the patients. And at the same time, we moved from that scallop soft tissue architecture into that tunnel-like approach, which is really not nice. So see how we started, and this is how we ended. So the question is, what is the rationale for bone reduction? Why do we need to reduce the bone before placement of the implants? I'll tell you, the majority of the cases, and I would say 98% of the cases that involve bone reduction, are just to facilitate it easier for the surgeons and the restorative dentists, because they can do the pickup in an easier way. That's it. Now, there are some arguments that come from a lot of colleagues, and unfortunately is being taught in a lot of institutions worldwide, not only here. They say that you need to reduce the bone in order to gain restorative space. No, I say do not reduce the bone because of this, because which literature, which paper said that you need to reduce the bone by, let's say, to gain 10 millimeters of restorative space? The patients had already teeth. So why do you need to reduce the bone? You just need to open your bite a little bit and then gain that restorative space that you're looking for. And the second thing, what is the scientifically proven evidence, or the evidence that we have in the literature that tells you that you need 10, 12, 15 millimeters in order to deliver a specific material? So since when we are going to start cutting the bone or advocating for bone reduction just for the sake for a specific material to be delivered, namely zirconia, let's say, orthodontic zirconia? Who said that in the literature? There's nothing.
I agree with you 100%, Wael, if I can interrupt for a second. What do you say about the argument of the smile line? You know, the argument is always beaten around the world is you don't know where the atrophy will end, and maybe you have the smile line exactly in the area where the restorative part sets on the gingiva. What is your take on that?
Right. So the only two indications, Stefan, for bone reduction, I summarize them. First one is whenever we have a knife edge alveolar bone. And that we see it a lot in the lower anterior, for example. You can reduce the bone in order to have a wider base to accommodate the implants, rather than, for example, the other option of augmenting the bone. But that might require 2 surgeries, right? Like, because you cannot install the implants if it's very thin. And the second one is like what you said, when we have visible transition in the aesthetic zone, high lip line, and then that would speak whether it's FP1, FP2, or FP3. Specifically in FP2 or FP3, if that transition zone is visible, then of course we can consider bone reduction in order to hide it underneath the lip. Those are the only 2 indications for bone reduction. If someone coming and telling you we reduce the bone because of restorative space, that I would say, sorry, that is not acceptable. Now, so whether this approach or the other approach, for me, we cannot go and say that we have one treatment that fits all. And we have to consider that our patients are individuals with individual needs, individual architectures, and our treatment should be customized towards delivering that customized treatment. So I will introduce I know that the 45-minute to 50-minute today is not enough to go through the whole thing, but I'll try to simplify the concept that my dear friend David Murray and myself, we've been working on since quite a few years and introduced recently, and hopefully is going to help expediting the work in terms of delivery of the full arc cases, and at the same time deliver it in a predictable way, and last but not least, maintain these valuable soft and hard tissue architectures that we would like to maintain. And as you can see here, as a short example, patient with terminal dentition, he was referred for the extraction, implant placement, and of course, all the treatment options were discussed with the patient. He was going to undergo later after a year He was planned to go for a therapy that is going to affect his bone metabolism. So they asked us to take care of everything before that treatment will be commenced. So you see the situation here, beautiful soft tissue architecture, beautiful bone levels around the remaining teeth. And we are planned to extract, place the implants, and load the implants immediately in order to maintain quality of life in terms of a fixed rehabilitation until the implants are integrated. So what we do in these cases, in terms of the workflow, we consider or we collect three types of information or data. For us, it's enough to take one portrait image of the patient, that smile, and then we need also to keep for an intraoral scan. And last but not least, we move on to get a CBCT. Now, with these three sets of data, we can create the so-called the virtual patient. And of course, we do more images, we take more x-rays and all of these stuff, but for that workflow, we need only these three different data sets. The next step is actually to develop a project, and that project is going to be two-dimensional first, and then it's going to be translated into a three-dimensional one. And we go back to conventional prosthodontics, we go for a wax-up. But here today, with the help of digital technology, we are able easily to go for a smile design, virtual smile design, there are many smile design applications out there, but this is, for me, the most realistic one that we can utilize, or photorealistic one. We just select the tooth shapes and the exposure during smiling. And that will be the baseline for what we call the blueprint. And because, of course, we have to know where the tooth position is, and we have to set this to dictate also where the implants are going to be. So the next step is going to be to try it in the patient's mouth. So rather than only looking at the computer screen, we are going to try it in the patient's mouth. So it's simply a mock-up. And then after that mock-up, we develop that project, which is going to be considering from that mock-up on the left-hand side, you see here, this is the initial design or the conventional mock-up model that we did. Remember, it's additive. We are adding to the tooth surface, so it's not really reflecting where the future tooth position is going to be. We move on to the so-called functional design. And the difference between that initial design and the functional design is that we bring the prosthetic component, which are the teeth, more inwards where they're supposed to be, and also upwards or in the lower downwards. Because once we extracted the teeth, as you know, Stefan, you are going to lose bone. You are going to lose soft tissue. And that shrinkage that we know in terms of the soft tissue is between 0.5 to 1 millimeters. Sometimes goes up to 1.5 millimeters, depending if you remove some bony architectures or the bone was very thin. So this shrinkage in the soft tissue will be taken care of also in the functional design, because we have a soft tissue component, meaning that we are going to sculpt and work on the soft tissue in a way that is going to simulate that shrinkage. So we are going to pull our papillas up, we are going to pull our soft tissue contours up and inwards, and then the temporary will be built in accordingly.
Well, how do you decide on the shrinkage? It's probably different in a perio patient to a patient losing his dentition because of decay. How do you interpolate that?
There is no rigid formula to do this, but we differentiate between the thin phenotype and the thick phenotype. And between these two, there is different. Patients with high scallop tissue, they are more prone to recessions compared to patients that are less in terms of a thick phenotype that is going to be less in terms of it. So we take into account something between 0.5 to 1 millimeters. Most of the cases, we go for that 1 millimeter, but very thick biotype, it's enough for 0.5 and you will get a predictable outcome. But again, you have a designer that is understanding or able to understand what are the biological changes that are going to happen along with tooth extraction. And then he or she will be able to sculpt the models virtually in order to compensate for these changes. And I hope that this will be automated in the future in order to make it easier for everyone. And now, of course, we move on to implant planning because we designed our functional. We have the functional design. We are going to dictate the implant positioning. We designed our temporary. We are going to translate that implant position by means of a surgical guide. And in addition to the surgical guide, we have another guide that is going to guide our temporary. So you have here a surgical guide, as you see on the left-hand side. In the middle, we have a prosthetic guide or a prosthetic cage or a positioning appliance where your temporary is going to snap in. And that guide, and that temporary differs from the conventional immediate temporaries that it has a pontic form. It simulates the tooth structure, and at the same time will be able to guide soft tissue healing properly. So you see here how the surgical guide is and how our temporary is snapped within the prosthetic guide, and the translation between the surgical guide and the prosthetic guide is actually the pins. The pins are going to guide from point A, or the surgical aspect, to the prosthetic aspect. And same applies for the lower. We did the upper and lower in this patient. And again, these have to be synchronized in a very good way. Now, the other feature of this kind of workflow is, since we recognize that all of our surgical guides, or the most accurate surgical guides, are those that are supported by the teeth, not by the soft tissue or by the bone. There is a debate in the literature in terms of which kind of surgical guides are the most accurate, whether bone supported or tooth supported or soft tissue supported. The literature is a little bit controversial in this aspect, but we do know that tooth-supported surgical guides are the most accurate ones. So why do we need to extract all of the teeth, lose all the references, and then rely on surgical guides that are really not as accurate as when you have teeth? Why don't you leave some of the teeth to support your surgical guide, and these teeth are not going to interfere with implant placement? You place the implants, and then you remove these teeth. So this is what we are doing in this concept, and that's why the concept is called STAR. It stands for Set 3 Acceptable Retentions. And then that's why you need at least 3 teeth or 3 anchorage to facilitate this. And we did like a video. This is the second time I show it. You see here we extract the teeth, and we leave some of the teeth to support the surgical guide, which is exactly the case that I'm showing you now. It comes and snaps on the teeth. Now we have a tooth-supported surgical guide. Now we go ahead, either we drill for the pins or we wait. I prefer to do the pins afterwards, but this is not the topic for today, because again, we have a tooth-supported surgical guide. We place the implants, and after we have placed our implants,
well, can I ask a quick question in between? So the pins are actually only there for the provisional. Did I understand it correctly?
The drilling for the pins, because we don't have for the rendering here the pins to facilitate them. Mm-hmm. So after extraction now, we go and put the multi-units or the other components that we like to go for. And then you see now our temporary that you have seen here is going to snap in and come on top of it. And then we utilize the pins to fix our guide in that 3-dimensional position that we are looking for. And then we do the pickup, then process our temporary. And if you look at the soft tissue now, the soft tissue is going to shrink and then come and adapt to how this pontic form is. And this is a simplified video to show you how the procedure works. And fortunately, I mean, David and myself, it takes less than 2 hours in our hands today from A to Z, surgical and prosthetic parts. So you see here in the upper placement or extraction of the teeth, we leave some of the teeth in the upper. We're 4 here left. We place the implants, and then we drill for the anchor pins after we place the implants. Simply because if you are going to tighten the implants or put them the mounts, your surgical guide is going to sink a little bit and compress, so that if you drill for the pins before, it might not be as accurate as when you do it after. That's why We rely on the teeth to support the surgical guide, and we rely on the pins to support the prosthetic guide. And then we do the pickup. Same applies for the lower. You see the situation here, both in the upper and the lower. And if you see here, this is how we started, and this is how we ended. And then the lower, it took about 1 hour, 50 minutes. And you see here the situation. You might ask, why did he leave the tooth there in the back? We leave the
good for the periodontist.
Good for the periodontist. I leave usually teeth in the back to support, like to work as stoppers, but at the same time, from a prosthetic standpoint, these can be used as reference for an intraoral scan later if you're going to stack different scans together. But if you see here how we started with a beautiful soft tissue architecture and we moved on to the temporary phase here, you see that the combination or how the soft tissue is beautifully adapting. After 1 week, we did not remove the sutures yet around the temporary. So you see here the digital design superimposed on the outcome. You see it is predictable what we are doing in terms of the situation. And that's what I wanted to summarize in terms of this concept, in terms of how we start by the planning, initial design, convert it to 3D, and then go from that initial design into a functional design, then utilize that functional design to plan your implant position, to plan your surgical guide, to plan your prosthetic guide, and then go for the implementation as I stated. And that's it in terms of the slides. And I'm happy for the discussion that you
wonderful. Well, that was beautiful. Thank you so much. I actually learned a lot. It's already good that I listened to you. So thank you. Great input.
Thank you.
And great expertise. So I really appreciate it. So please, we have a lot of visitors and guests. We have Eva from Serbia, we have Alberto from Spain, we have Ben from Tunisia. So from all around the world, while people are listening to you, please ask your questions, because if you don't have questions, I will have a lot of questions to Wael. And well, we have one question here from Turka. Hi, Turka. I think you're logging in from Istanbul. Probably way better weather than we have. Wael. He asks you a very obvious question. You are using a splint which is supported by teeth. What do you do, my friend, when there are no teeth?
We use the anchor pins then. We can move to the utilization of the anchor pins to support it. We prefer not to, whenever possible, not to open a flap. However, for any colleague who is doing this for the first time, or like done a few cases, you have to consider many things. And I know that you're going to like this, Stefan. As a periodontist, it's very important to consider the remaining amount of the keratinized tissue that you're going to have buccal and lingual of the implant. So when you are planning for it, think about that. What are you going to end up with? How much of the soft tissue is going to be remaining? If you're doing flapless in that approach, usually you go with that soft tissue punch. And then, of course, you have no possibility of repositioning your soft tissue where you would like to have. So if you have limited or no amount of keratinized tissue, I would highly recommend to open a flap, whether it's a big one or localized one around these specific implants that you are going to install, and then just push the tissue more to the buccal. So you'll have that keratinized tissue that you're looking for at the end. But to answer your question, if you would like to go for, if you don't have any dentulous patient, you can go for the anchor pins as a way for anchorage for both guides.
Yeah, in particular with the amount of keratinized mucosa, I find that difficult to also judge where the attached mucosa will be going after immediate implant placement, right? In particular, after perio cases, you sometimes have a vast amount of keratinized mucosa, but probably because of inflammation or whatever, and then you place your implant and suddenly it's gone, right? And you're a little in trouble. So as I understood you correctly, these would be cases where you open a flap and sort of apically reposition also the tissue?
Not only apically, but also buccally. Let's go, for example, in the upper, we'll go for a more of a palatal incision and then reposition everything more to the buccal aspect in order to get that keratinized tissue. And I have to say, by recognition, in terms of recognition of where the keratinized tissue is, changing the colors or the viewing in the intraoral scan is a very helpful tool to see where your keratinized tissue is, where it starts, or that mucogingival junction is. And that is really, really helpful. So just view and look at all of the details in terms of your intraoral scan and the PLY format, because it includes the colors. So you look at it and then you will be able to recognize where it is, or even from the photographs that you have done.
Yeah, thanks. Well, there's a question from Eva from Serbia, which a little bit points also in the direction of what we were discussing. Would you also consider to sort of simultaneously augment soft tissue in these cases, because we're also alluding to thin cases? Would you consider that, or would you do that in a staged approach then?
No, I think you can do it at the same time, since you are delivering your temps at the same time. So you will enable that for soft tissue healing the way that you would like to. So yes, we do when it's needed. And the purpose of soft tissue augmentation is not to coronally position the tissue or something like this. The main goal is actually to enhance tissue thickness around that area. So of desire. And this, we see it a lot, for example, if you're doing FP1 type of rehabilitation in the upper anterior region, on the lower anterior region, mostly in the upper, especially when it's a visible area, then I would recommend to go for soft tissue augmentation. But very few number of cases we do it because your implants are placed more to the palatal aspect. So you have the alveolar ridge or the extraction socket, you are going to put the bone grafting material, and your soft tissue is going to adapt. Since it's going to shrink, it's going to be automatically a little bit wider or thicker. So you don't need it that much. And we have very few cases where it needs it. But yes, if you're going to do it at the same time.
Perfect. Thanks. I think, Eva, that helps you. Well, I have maybe one more question. The perio guy is asking the prosto guy, so be careful now. You were actually alluding to that you like a metal framework in your provisional. Maybe I misunderstood it. That was maybe one of your earlier case. I haven't seen any metal framework in the provisional you are now using. Yes. Is that because materials have changed, or did you change something in the diet of the patient? Because I still, to be honest, this is my greatest fear, that after 4 weeks, after immediate implant placement and immediate loading, the provisional breaks and the patient just doesn't get it, and then you lose implants, right? Yeah,
it's all about, well, we have two folds of this. The first one is actually material properties, and we do know that previous materials and that's why we went for metal support or metal frame, subframe, because it has been all handmade back at that time, meaning that your temporaries or temporary material, which is PMMA back at that time, it's porous because it's handmade. So basically, it will not be as resistant as the so-called machinable materials today. You can utilize PMMA today, but if it's machinable, so it's coming out of the puck, it's going to be milled, or even 3D printed materials, it is at least 8 times stronger than the conventional PMMA. Now, the second part of this is the design of your temporary. Of course, you have to plan it bulky enough, even bulkier than the final restoration, in order to give it the resistance that you're looking for. Yet at the same time, you have to be aware that your bulkiness should be not towards the occlusal plane, but towards the more of the coronal or the apical portion, in order to avoid any kind of flat, big surfaces for the loading, which are going to lead to excessive loading and might also fracture it, or maybe lead to greater load onto the implants. So twofolds, the material properties today changed because they are machinable, they are better. And the second thing, design optimization. These are the 2 key factors for for our temporaries.
Does the diet play a role in the first 6 to 8 weeks?
The diet, of course. Yeah, I mean, we ask the patients, we tell them first 10 weeks, not only the first 10 weeks, because we guarantee that they are going to be taking care at least for the 8 weeks, and then they're going to start losing, being a little bit not considerate. We know that your implant is placed first. The mechanical is like as if you're drilling a screw in the wall, and that mechanical stability is going to be replaced by the biological stability over a period of 8 to 10 weeks, depending also on the patient's bone metabolism and the bone forming unit, or the BFU, which we know that it grows about or has a speed of 40 microns a day in terms of bone healing. And that of course will need some time to establish the osseointegration. And yet after 8 to 10 weeks, still it needs to continue mineralization in order to get the hardness, the stiffness over time. So I think it's very crucial to have a patient on a soft diet. Some patients, they go automatically on a liquid diet. They say it's an opportunity to lose weight. But at the same time, it is something that all of us understand. Soft diet over a period of 6 to 8 weeks, but we say again 10. And then, of course, then they can start gradually eating something more. And by that time, if something happens, we're going to replace the temporary. We have no problem of removing the temporary or putting a new one.
Thanks. Well, I also will change that. I always said 6 to 8 weeks, but I think you're right. Be more on the safe side. That's a very good point. Well, first of all, we have a lot of congratulations to your presentation in the chat.
Thank you.
People are applauding from all around the world. So we have Robert Haas from the EAO board telling you that this was a great presentation from Vienna.
Thank you.
We have a lot of other people congratulating you. There's one more question pointing also in this direction from Per, also coming from Norway, I guess already also quite snowy there. So he asks you, how are these provisionals manufactured? Are they milled? Are they printed? Maybe just a very short take on that.
Yeah, I mean, we do know that millable materials or machinable materials that are going to be milled, namely PMMA, are still stronger than temporary materials that are 3D printed. But there are 3D printed materials that have similar resistance properties and flexural strength compared to the conventional millable PMMA. I do prefer to go for the milled version, yet if there's a need and we have an issue, we have the digital file and we can 3D print using materials that are approved to be utilized, let's say, as temporaries, long-term temporaries. So you can choose between both, but I still recommend, due to the limited amount of manufacturers that are delivering these kind of 3D printed materials, to still go for machinable or milled temporaries using PMMA. You can polish it easily. If it fractures, you can repair it easily. If there's a crack on it, you can add something like this in a quick way and a predictable way. Plus, we have learned over the years that soft tissue response to these machinable or millable PMMAs is very good as long as they are well polished and they have no contaminants on their surfaces. So basically, just my recommendation is polish them as much as you can, and then have them well seated and facilitate the proper hygiene in terms of the design, so nothing will be stuck there and then go inside, and then you will have a perfect result.
Well, thank you. Again, people applauding you. Maybe one more final, a little bit polemic question. How do you move your people going to the final restoration when you have these kind of beautiful provisional restoration? Does that work, or are they staying on these provisionals? At least this is sometimes what I have the feeling in my office. Does that happen? You
know, all of us, we face the same thing, but I think as clinicians, we are obliged to actually deliver the best that we can for our patients. So I don't really care if the patient is saying, okay, the temper looks so nice, I'm going to go and come back, or I'm never going to come back there. It's already paid so much money. But we do know that these are not going to stay forever, and they are going to degrade at some point. When they go into wear, they are going to discolor. We see patients coming actually after 4 or 5 years for final restorations because they wanted to stay as long as possible with the temporaries and save money in order to get to the final stage. That's fine. It's all fine. But the patients need to understand from the beginning that they are getting a temporary, whether it's high-end or not high-end, but at the same time, this is not forever. Just tell the patients, for us, we have to take care of details and be able to deliver the best quality possible to the patients.
Very nice. Wael, this was fantastic. I think we're through. We had a lot of questions. I think we had a great talk. I actually learned a lot. Thank you for your expertise. It was an enormous pleasure to have you here. So first of all, everybody's applauding to you. So again,
so
very warmly, thank you very much from my side, but also from behalf of the EAO. Thank you for having this presentation.
Thank you so much, Stefan, and thanks for the EAO for giving me this opportunity, and for everyone who attended today. I look forward to next year's EAO in Italy. So I'll have the honor to lecture there. So I'm looking forward to see you and see everyone there.
We will be looking forward to that Congress, but very good that you point into the direction of more education. If you're interested in online education, the EAO is just starting the EAO First Certificate in Implant Dentistry. It's 100% online. It's translated in over 10 languages. It will start in January. Please look at the web page, look at the EAO homepage. It's a great opportunity to learn online, flexible, and I think that's a good way. With this, Wael, I would like to thank you. The next Just Ask will be in January, 8th of January. Maybe you are one of the participants. We would be very happy. We will have Bjarni Petrusson on sinus lifts, which is also interesting. So again, to everyone all around the world, and especially to Wael, thank you very much. Have a great end of this year. Have a great Christmas season. Have great vacations, and ciao, ciao, goodbye all around. Thank you, Wael, and thanks to everyone for listening. Thank you.
Happy holidays, everyone. Thank you so much. Bye-bye.